We are going to start because we have a packed agenda. And today we're going to talk about phenotyping all the way from formulating your research question to developing phenotype, to evaluating phenotype, to storing and maintaining the phenotype. And there's going to be 4 blocks. After each block, we're going to have a short time window for questions and answers, and then we're going to have more time, hopefully at the end of the workshop, for more discussion. And there's going to be a lot of information, and what we want you to get at the end of it is the understanding of the pipeline, of its conceptual principles, and knowing what tools you can use for each of the steps. While I will not go into much details about each step, there is a reference file, and we will have it at the end of the workshop so that you can click on this QR code and see it, and that reference file references all the tools and all of the supporting materials, additional workshops, additional videos, additional documentation for you to learn in more details about each of the steps. And with that, we're going to start with Anna, who will talk about the, she will tell you what she's going to talk about.
Yeah, hi everyone. So, well, I'm going to talk about what a phenotype is, what we refer to phenotyping in real-world data, and also I will give you an overview of the phenotyping process and how to start when we decide to, or we have to phenotype, for example, a specific condition for our study. So first of all, what a phenotype is, I'm sure you have heard about a difference between phenotype and genotype. Phenotype refers to observable characteristics, genotype is derived from the genetic makeup, and a phenotype in real-world data refers to the inference of patient characteristics through the data coming from electronic health records, claim data, registries. And we refer to the phenotype algorithm to the algorithm we use to infer these patient characteristics from this real-world data. So when we are talking about phenotyping in real-world data, we mean that we aim to identify the patients in this real-world data that have or had a certain condition, that are using or used in the past certain drug, receive a certain procedure, or individuals that have certain characteristics. So this is an illustrative example of how observational data looks like for a person. This could be like the clinical history of a patient. So in yellow, we have records for different conditions. In dark blue, we have records for different drugs, and in light blue, we have records for measurements. And then each of the rhombus represent each time that this condition, this drug, or this measurement has been recorded in their history. So, for example, here we have records for type 2 diabetes, hyperlipidemia. Then we have records for specific treatments that are used to treat type 2 diabetes, hyperlipidemia, and also measurements that we use to monitor or diagnose these conditions. So for this individual, from the data we have in their clinical history, we could infer that this individual had type 2 diabetes mellitus. I know you can see how to point it, but that it has type 2 diabetes mellitus. And here, for example, we can see like the start of type 2 diabetes. We are not taking into account from the first record of the condition, but we are taking into account from the first record of the use of metformin. That is the treatment used for treating type 2 diabetes. Another condition that we can infer from this data is hyperlipidemia, and we can see in the second row of the conditions how this patient had three records of the condition hyperlipidemia, and the start of this condition of hyperlipidemia is aligned with the atorvastatin use, that is the treatment used for hyperlipidemia. And if we look in the measurements in the second row, total cholesterol, it's also aligned with the first measurement that defines hyperlipidemia. So we can see that how we have inferred hyperlipidemia for this patient. Also, we have acute event of acute myocardial infarction, and also we can see how, just from measurements at the bottom of the graph, we can see how this patient has 2 measurements of body mass index defining obesity. So these are all the conditions that we could infer for this patient looking at their clinical history, looking back at the real world data from this patient. So from the same data, we can sometimes, there are some potential errors that we could commit when we are inferring these conditions from the data. For example, the first one I already told you, for the type 2 diabetes, imagine that you are just using codes from conditions to define type 2 diabetes. Without looking to the treatments or without looking to the measurements. Instead of defining the start of, you will have defined the start of the type 2 diabetes with the first record of the condition. But if you look at the whole data of this patient, you could see they was having the treatment for antidiabetic before the first record of the condition of type 2 diabetes. So if we have used just a code for the condition type 2 diabetes, you will have been misclassifying the index date, meaning that we will have incorrectly assigning the start of the condition for this patient. Another potential error that we could have, as if you see the third row for the conditions, essential hypertension, this patient had 1 record for essential hypertension. If we would have defined this condition just using a code for conditions, we would have said that this individual had hypertension since the first record of hypertension. But we have also data for measurements. And then we can see how systolic blood pressure, we have 3 measurements, and we can see how the measurement was a normal value. So it's likely that the single record of hypertension for this patient was an error. So we will have misclassifying this individual as having hypertension but when we are looking at the measurements, we can see how this individual does not have hypertension. And finally, with the obesity, we could see through the measurement data that this patient had obesity because it has the several measures of body mass index indicating obesity. And if we will have defined obesity just using condition codes, not measurements, not looking at the measurements, we will have missed this condition. So now we know what a phenotype is, how we can infer conditions from observational data, and I would like to highlight how the OMOP common data model and one of the key features of the model, like this is standardized vocabularies, led us to have standardized phenotypes. Like all the databases have been mapped to an OMOP common data model that uses standardized vocabularies, meaning that they have mapped their source data to this standardized data, and this helps us to simplify the process of phenotyping. For example, if we are working in a federated manner, we are working with many databases, we will have the code that we need for phenotyping, for identifying individuals with a specific condition in a database, such symptoms, diagnosis, lab tests, medications, complications, in different databases look like really different because each database is using a different vocabulary. But when we are using databases that have been mapped to the OMOP common data model, as all of these databases have been mapped to the standardized vocabularies, all the databases are speaking the same language. So they are all the codes that are going to define our condition, our drug that we want to phenotype, uses the same vocabulary. So this simplifies a lot the process of phenotyping, and this helps us to have a standardized phenotype that could be used across all the databases, that have been mapped to the OMOP common data model. So here we have the phenotype life cycle. These are the main steps through the phenotyping process. The first step is the phenotype definition. We have to understand the condition of the drug that we are phenotyping, and for that we will create a clinical description, and we will use prior knowledge, the knowledge of an expert, or we will conduct a literature review to understand how the condition has been already defined by other researchers. Once we understand the condition, we have defined the phenotype, then we have to start developing the phenotype, and for that we will have to create concept sets or list codes, the list of codes that we will use to go to the database and identify the patients with a specific condition, and we also will have to define our cohort. We will have to define some criteria that individuals that are going to be included in the cohort that we are going to use needs to meet. Finally, when we have created the cohort, we'll have to evaluate if the phenotype is correct. We'll have to make sure that the individuals that are included in our cohort represent the individuals of the condition that we are phenotyping. For that, we will conduct some assessments, some diagnostics that we will show you later. And then once we are sure that our phenotype is validated, that our phenotype is representing correctly the individuals, for example, with type 2 diabetes, then we will have a ready phenotype to be used in our study. Then we can use it, and then the last step is to store this phenotype. As I said, we want to create standard phenotypes that can be reused for future research, and then we have to store this phenotype in the library, and also we have to take into account that this phenotype has to be maintained. For example, today you are creating a phenotype for type 2 diabetes, and then you will be creating some code list with the current vocabulary version of April 2026. If someone wants to reuse this phenotype in 2 years, the standard vocabularies in OHDSI are being updated, so this code list will have to be updated to the most updated vocabulary version. So also it's really important to maintain these phenotypes that are stored in the libraries. And then what a cohort is, right? So a cohort is a group of persons that are satisfying one or more inclusion criteria for a duration of time. And then we refer to the cohort era, to the continuous period during which a person is meeting the cohort's inclusion criteria. In this matrix, you can see each row represents an individual that is meeting your inclusion criteria. So all of these matrices are representing all the subjects that are included in your cohort. And then the cohort era is in the first row. You see that you have the cohort start date and cohort end date. It's the period within each person is meeting the inclusion criteria that you have specified for your phenotype. There are 3 key components for a cohort. First, the domain. A domain defines the set of allowable concepts for the standardized fields in the CDM tables. You define when you have the code list, where you will find this code, in which domain, condition, measurement, drug, procedure. Then another key concept, the concept set or code list, the list of codes or the concept set, that is the logic expression of a code list that you will be using to go to the database and identify the individuals with this condition. And sometimes you will be defining one or more concept sets for your phenotype. For example, for type 2 diabetes, you could combine concepts for the condition of type 2 diabetes, concepts for anti-diabetic drugs, and concepts for measurements. And finally, the temporal logic. So this is the time intervals within which the relationship between an inclusion criteria and an event is evaluated. So sometimes you will be applying inclusion criteria, such as having a condition during the period year of starting a specific drug. For example, you have to apply a time logic within the inclusion criteria for a cohort. So what are the initial events that define the cohort entry? When you think of a cohort, you will define the cohort, and it's really important that you define when your cohort is going to start and when your cohort is going to end. So you have to think which will be the initial events that define the cohort entry. So you will define it by the existence of any observation related to condition, drug, measurement, procedure, and you should not define it by the absence of an observation, because the thing that we don't have in the data, we are not sure if it's that it doesn't happen. This is real world data, right? If the data is not there, this doesn't mean that the person does not have this condition. And also, we should not be defining the cohort entry by age, because age requires to be anchored to a time index. And finally, also, we have to be very cautious when we are defining a cohort entry by calendar date, because we can cause observation bias. For example, if you define cohort entry by the 1st of January, maybe by that time, not all the individuals visit the healthcare system, so we will not have information for all the individuals, and then we will be creating some bias. Instead, we could define it by a visit that occurs within a study period. And then, as I said, it's really important also to define the cohort end, not just the start of the cohort, but also when our cohort is ending. And sometimes we don't have to confuse the cohort end with, for example, the censoring time in the analysis, because the censoring is referred to the time analysis. And sometimes, like the time in observation, like the time where a patient is or an individual is within a cohort, will not align with the time in the analysis. Sometimes we will want to, for an analysis, we want to be describing an acute event. So maybe we will just, for the analysis, we will just take into account the first year after the diagnosis, but for the analysis, we will be following the individuals until the end of observation. So when we are defining the time within the cohort and the analysis time, we have to think that they are related, but they always don't align. So you have already seen the overview, so now we are going to start with phenotype. As I said, the first step is the phenotype definition. We need to understand the condition that we want to phenotype, and for that we will start filling the clinical description. This clinical description will gather all the information related to the condition, and this information will help us to plan the phenotype, to understand which are the concept sets that we have to create, if we are going to include one or more concept sets, how we are going to combine them, and also it will help them to plan the definition of our cohort. Also, this information is really important because we will use this information for the diagnostics phase. Once we have created the cohort and we characterize this cohort, we will be comparing the characteristics of the cohort with this information. And they must align so we are sure that we are correctly identifying the individuals. So for this workshop, we will use the use case of rheumatoid arthritis. And just to explain you briefly what are the sections of the clinical description, we need to understand the presentation of the condition, how the condition is diagnosed, some features from the epidemiology, the incidence, the prevalence, age and sex distribution, important risk factors, how the disease is treated, and information related to the survival, complications, and all of this is what we will be using for the phenotyping plan. So this is a slide taken from the clinical description of rheumatoid arthritis, and just to for those who don't know, it is an autoimmune condition, meaning that the immune system attacks the body, and specifically it attacks the joints. It's affecting around 1% of the general population, and it's more frequent among female. So the symptoms are related to having swelling among different joints, pain, stiffness, and also there are some other symptoms such as fatigue, skin nodules. It's diagnosed by image, but also by some different measurements. There are different differential diagnoses, including osteoarthritis, psoriatic arthritis, lupus, among others. There are different treatments, treatments for managing the pain, like NSAIDs, corticosteroids, and also for treatments that are more specific for modifying the disease, including the disease-modifying antithrombotic drugs and biologics and JAK inhibitors. And there are some complications, including the lung and heart involvement. So all of this information is what we are going to use now to think of the concept sets and the definition of the cohort for creating this phenotype. And also, this information is the one that we are going to use when we are reviewing the cohort that we have created. So, for example, when we are creating the cohort and we are characterizing the cohort, if we see maybe we have a prevalence of 30%, and we know that the prevalence is around 1%, we see maybe something is happening. So you have to compare the characteristics you have from your cohort with the information that you have gathered in the clinical description. Yeah. Thank you. I don't know if we make questions here. Yeah, I don't know if anyone has any question. Yeah. Yeah. Yeah, we usually recommend once we already have a phenotype and we want to use it in a database where the diagnostics have not been done, we always recommend to do the diagnostics, just to be sure like the phenotype also works. Like we don't have to go to the first step, but to make sure that maybe I don't know, maybe this comes from the source data, maybe, or there was a mapping issue or whatever. So we always recommend, and we also always do this, we always do the diagnostics before using it in our study code. This is the recommendation I will give you. Anyone else? Yeah. I mean, yeah.
Was when do we go to the phenotype library and take the phenotype from it versus develop something new?
Yeah. So I recommend, like, before starting from scratch, you always go to the library, you check whatever is done, and then you try to understand, like, you will have some metadata, like the phenotypes are stored with some metadata behind, meaning like the definition, the study where it was used. Sometimes, for example, when we create a phenotype, it can be used for a prevalence study. So you will be creating a prevalent phenotype. So you store this information, right? And if the definition and the study match your study, you can reuse it, always going through the diagnostics, of course. But imagine that for your study, you just want to include newly diagnosed individuals because you want to estimate incidence. Maybe you cannot reuse it as it is, but maybe you can have a variant from this phenotype. Does it make sense? Yeah, okay. Any other questions? We can move on. Thank you.
So this section was meant to be, was prepared, it was meant to be given by Masha. Masha's flight got canceled, and she's only arriving today at 1 p.m., so you'll have to listen to me for longer than was initially intended. But to make it easier on you, I'm gonna talk for approximately 20 minutes, and then we will do an exercise. So if you're thinking about falling asleep, you can power through the next 20 minutes, and then we will have something that is more fun than just sitting and listening. And when we define the clinical description and we do the literature review, we then jump into developing a phenotype. And that consists really of two elements: creating the concept sets and assembling them using some sort of logic. And here we talk about the rule-based phenotyping. This workshop in general doesn't consider probabilistic phenotyping. So everything we're talking about is really rule-based. And when you think about the concept sets that you may need for rheumatoid arthritis, you can think of different buckets. You can think of diagnosis codes, and really lots of the times people stop there and think, okay, I just need diagnosis codes and that would be enough. But you can also consider other buckets. You can consider coming up with a concept set for symptoms for rheumatoid arthritis, such as joint stiffness. You can think of the other diagnoses that clinicians need to rule out to determine that a patient has rheumatoid arthritis. You can think of the lab tests that are used to diagnose rheumatoid arthritis, such as rheumatoid factor or antibodies. You can think of the treatment procedures and drugs used for rheumatoid arthritis, or you can think of complications. And all of these building blocks are at least one code list or concept list, a concept set, where each of them consists of one or more codes from the vocabularies. And we talked about how we map different source terms to standards in OHDSI vocabularies. And when it applies to conditions, we in the source data would have ICD-10, ICD-9, read other codes depending on the source, but all of them are mapped to the common reference standard in condition domain SNOMED. And you can see here on the slide that ICD-10 rheumatoid arthritis unspecified, ICD-9 rheumatoid arthritis, read rheumatoid arthritis, all of them are mapped to one single concept in SNOMED. There are also other codes in the source terminologies that would map elsewhere. For example, here there is an ICD-10 code in the source data indicating seropositive rheumatoid arthritis that would be mapped to a different concept in SNOMED that entails the same clinical notion. And luckily, we do have vocabularies and hierarchies within the vocabularies so that those individual codes are linked together using the hierarchy. And you conveniently can use that by selecting, for example, rheumatoid arthritis, retrieving all of its kids, or as we call them, descendants, and getting not only rheumatoid arthritis, but all of their subtypes and different specific codes. But on top of that, there are other codes that would live completely in different locations, unrelated to the main branch. And this is really the main challenge of creating concept sets, is that the space is really big, and you do not, at each point of time, quite know if you captured the whole space, or there are other codes left that you would like to include. And what we're trying to solve is really primarily this problem, because unless you know to look for those codes, you wouldn't be able to see them and to make your judgment about whether you want to include them. And our solution that we come up with a pipeline many years ago is to use informatics tools to help us in this process. And the algorithm specifically for conditions, but it also applies to the other domains, is that you start with a clinical description. You will hear us talk about clinical description all the time because it's really important. And if anything, if you do anything for phenotyping, you really got to make sure that you have this clinical description to drive all of the subsequent steps. So you have this clinical description, you've done literature review, then you need to find the proper starting point where to start your concept set. Then from there, you can use the tools that we have available to get other additional codes to look at them, the recommendations, and see if you want to include those. And you look at the recommendations, you assess them, you include codes, you iterate some more, and at the end, you get a concept set that you believe is a comprehensive concept set. And at the bottom of the screen, there are several tools that we use in OHDSI to create concept sets. Now I'm going to show you Phoebe, which provides recommendations in Atlas, but there are other tools as well. And if we wanted to do a concept set for rheumatoid arthritis, we would need to start somewhere. So we would go into Atlas, and hopefully you've seen Atlas. I really do hope that you've seen Atlas. Otherwise, the level of this workshop is really not appropriate. You would go into the search tab, and you would type in rheumatoid arthritis. But instead of clicking enter or hitting enter or clicking search, you would click on the green shopping cart. Oh, yeah. Wait. That is, let me see how I operate my own laptop. Oh, I probably need to exit. And now you should see my whole screen. Thank you, Dima. Okay, let me make it really big. So you would go into search. You would type in rheumatoid arthritis. Instead of clicking on the search, you would click on the green shopping cart. And what that would invoke, it would invoke Phoebe, which will try to find the starting point for you. And what it does, it looks for similar terms that match your input string, but it also uses counts from the evidence network. This is the network of many data sources that contributed information about their data to Claire Blacketer, who manages the network. And we can use those counts to prioritize the terms that have the most patients with this term, so that when you start with a code that is actually used in the data, as opposed to just term that has 0 counts. And in this specific case, it retrieved a suggestion of the starting point that is rheumatoid arthritis. So it is full equivalence. In other cases, it will be different because it will suggest something that may look similar that you want to consider as a starting point. In this specific case, it is a verbatim match. And it also already clicks descendants for you so that it not only includes the code itself, but also its descendants. And after we have the starting point, if you remember, the next step is to look at the codes that are retrieved. And in this case, even though we selected one, and no, it's too big for me, even though we selected one term plus all the descendants, it retrieves 140 concepts, which kind of highlights the hierarchies that we have in place in the vocabularies. You select one term, you get a lot of other terms. 135 terms come from SNOMED. There are codes that come in from CPT4, and there are codes coming from SNOMED OMOP extension. So already we can see, even though we included just one term, we're bringing in a lot of different vocabularies and a lot of codes. And what we can do here is we can order by descendant record count. So this first column here, RC or record count, indicates how many records there are in the evidence network loaded on this code. So here we can see there are 72 million records of patients that have rheumatoid arthritis in their data across the network. If you have your own data attached to your atlas, you will see also counts for your own data. Descendant record counts is the counts of rows of this code plus descendants. And we can see that with the descendants, it's 160 million patients. That corresponds to 6 million patients who have this code, PC, and DPC is the number of patients who have this code or its descendants in their data. And the very first step is for us to look through these codes to see if we want everything. And here we are only concerned about looking through the whole list and identifying any of the things that we may not want. We see rheumatoid arthritis, we see seropositive rheumatoid arthritis, seronegative rheumatoid arthritis, rheumatoid arthritis of multiple joints. We want all of this in this list, but those choices would depend on your clinical description. In this case, we want any patients with rheumatoid arthritis who were good with the whole list, even though we're not going to review the whole list with you for the sake of time. The next step that you want to explore is the source codes. So we started with one code plus descendants that retrieved 140 concepts that are standard that corresponds to almost 1,000 source codes. So you immediately can see how just by selecting one concept, the mappings plus the hierarchies get you 1,000 concepts. And there is ICD-10-CM that is included, that is used in the US. There is ICD-10-WHO that is used elsewhere. There is KCD-7 used in Korea, ICD-10 China used in China, READ used in UK. So all sorts of vocabularies that have codes corresponding to rheumatoid arthritis. And one would again look through the list of these codes to see if there's anything we may not want. And if you're interested in specific vocabulary, you can prioritize that. But the key idea here is that we do want to review included source codes to make sure that everything that we see is what we want. And on top of that, I think this tab highlights the fact that coming up with the flat list of codes is really hard. If I were to do a study and I want to study rheumatoid arthritis in the US on ICD-10-CM, not even taking ICD-9-CM, I would need to come up with a list of 375 codes alone. That is a big list, and I'm not quite sure I would be able to come up with the list of codes that would have all of these. So really, that showcases the benefit of using both the mappings and the hierarchies, because it would be really hard to come up with the lists on your own. And at this point, we looked at what this code set, code list has. Now let's look at what it doesn't have. And again, recommendations we thought are really useful because you cannot make any choice unless you know there is a choice to make. So unless you see the codes and think about them, you really do not have an opportunity to include other codes that may be useful. And these recommendations, there are several types of recommendations that we have, and we will go one by one through them. One of the types of recommendations, this is a pre-commuted file that is attached to Atlas. One of the types of recommendations is ontology related. This type of recommendation leverages all of the known maps to relationships in the vocabularies to propose some of the terms that you may want to include in your concept set. In this case, it suggests rheumatoid myocarditis, which is rheumatoid disease manifesting in your heart. In our clinical descriptions, we said that there can be involvement of other organs, so we do want this code in our concept set. If our clinical description said we don't want other organ involvements, our choice might have been different, but in this case, we do want rheumatoid myocarditis. And we wouldn't be able to really capture that code unless we knew that we need to look at it. So now we saw it, we made a determination that we want to include this code. We can click on it, we can add descendants, and we can add it to our concept set. I will go through other recommendations first before adding all of the recommendations to the concept set. Another type is patient context, which looks at disproportionate co-occurrence of other codes with the codes in your concept set in the patient data. So we took the real patient data, we did an analysis. The code was actually created by the person who sits right there, Patrick Ryan, and I can only see his head. And this analysis essentially looked at the other terms that occur together with your terms in the patient data. So you may want to examine them. And what it shows us is a rheumatoid lung disease. So that's yet another manifestation of rheumatoid arthritis in other organs. We included myocarditis. We do want to include the lung disease, given our clinical description. And we can see that would add us 400,000 records and 65,000 patients that otherwise would not be included in our study. We can also see arthropathy of multiple joints, which is way too broad, but it shows us that a lot of patients with rheumatoid arthritis also get those broad codes in their data around the code of rheumatoid arthritis. We don't want it here because it's way too broad, but we do want the first code. So we want to click on that too. Then there are lexical via source and lexical via standard. In a nutshell, these are just lexical similarity-based recommendations. So what are other codes that look similar to the codes that are in your concept set? And you can see that rheumatoid lung disease, we clicked on that already, and it already popped up under different recommendation. Because it also looks lexically similar to the concepts in our concept sets. And we would go through this whole list and we would see if there are any codes that we would like to add. For example, right here staring at us, there is myopathy due to rheumatoid arthritis. We included myocarditis, we included lung disease, we may want to include myopathy as well. And in the similar fashion, we would go through the whole list. Here it's actually only 18 entries, and we would see if we want to add any of those codes. And again, none of these codes were included in the initial concept set, so unless we see them, we have no means to choose if we want them. So this lexical via source, lexical via standard, both of these are lexical, they just use source and standard terms correspondingly. There is also ontology parent that shows you the parents of the terms included in your concept set, so that maybe there are broader terms that you want to include. And this list would always have a very broad generic terms because we're taking parents. So there's going to be disorder of thorax, disorder of free lower limb, osteoarthritis, and usually it is a pretty broad list of things, but sometimes we do get jewels there. And if we were to scroll down, which would take us much longer in real life, we would see things like extra-articular rheumatoid process, which is a word for all of the rheumatoid arthritis that manifests in other organs other than joints. And we do want that. Now, I jumped right into the end. If I were to do that on my own and I didn't have this time limit, of course, that would take much longer. And I would go through the whole list one by one, seeing if I want to include something. So now we added a bunch of things. So let's see what we have now as the concept set expression. We have rheumatoid myocarditis, we have rheumatoid lung disease, rheumatoid arthritis, myopathy due to rheumatoid arthritis, and extra-articular rheumatoid process. At this point, this is really not the final concept set. You would want to go back into your recommendations and see new recommendations because these are dynamically reassembled. And for example, now we don't have any ontology related because we included all of the ontology related recommendations into our concept set. So you would take a couple of iterations. Spoiler, that is not really the final concept set. There are a couple of codes that we're missing here. For the sake of time, we're not going to go through the extensive process of doing that. Nonetheless, there is a whole 6-hour workshop dedicated to that that goes into much more details on creating concept sets alone. And if this is something that interests you, please, we are going to have links to that workshop in our reference documents. Please go to that extended workshop. But let's for now pretend that this is our final concept set. Good, we have it. What do we do then? Well, then we need to assemble our... Oh, there is a question. Yes, please go ahead. So included concepts and included source codes are the things that are already in your concept set. So you don't need to add them, they're already there. But if you see something that you don't like, for example, let's say I really don't want seropositive rheumatoid arthritis for whatever reason, you can add it, exclude it with descendants, and through that your definition would say, I want all of these things, but not seropositive rheumatoid arthritis with the descendants. So there is a way for you to exclude things, but in a nutshell, both of the tabs only show you what you already have. Yeah, let me actually pause here and see if there are any questions so far. Yes. It will allow you, but you would do it in a different manner. So you want to, that speaks more to how Atlas works, but if you wanted to include a specific source code, you would need to do a different manipulation. There is a workshop, not a workshop, but video on that topic too that we have in the reference file. And if you're actually interested in that, you can also come to us after the workshop. I'm going to show you how to do that, but there are several steps that you would need to take in your cohort definition.
Yeah, but should we just say that in general, you just need to find the target concept? It was mapped. So if you don't
or you can do that.
Very short, but it might not work always because of mapping peculiarities. But basically, if you want some source code not to be shown, you take the source codes, look for its target equivalent, and then exclude that target concept. But sometimes something else was mapped to that target concept as well, and then it leads to exclusion of another source code. So that's why I said it might not work in all cases. But overall, like rough, you go, use mapping, takes target, and then use that target as an exclusion.
And I would love to show you the mappings, if only I can. But I think it goes into much more details of how to use Atlas. So that's why I said that you absolutely gave a very nice description. But I think if you actually don't know how to use Atlas and you want to learn that, we would have materials for you too. But this workshop does not really focus on the specifics of how to use Atlas.
So basically, we're not by my simple answer, I'm not trying to discourage people to watching that 6 hours video.
that is not true, because it goes more than this, than your answer.
More than 6 hours.
What we have there is more that you answered.
Yeah.
That was a very good answer. And Dima said, follow the maps too. So since we're on the topic, this is the way you would do this. You would click on the concept, you would go to the related concepts, you would find relationship that says non-standard is standard, and this will give you a standard counterpart for you to exclude. Alrighty. Are there any other questions? Yes, there are two. Wonderful. Yeah, so the question was in this tab, what mapped means. I never use it. I really don't know what it does. And even if it does anything, we never really use it. And there was one, and I'm sure there is an answer. I don't know it, and I never felt an urge to actually know the answer because we really do not use it. If the recommendation tab results are pre-calculated, they are pre-computed. The counts are coming dynamically from whatever you're using. It can be network, it can be your own data source. Yes, from your Achilles report counts, or from evidence network that is connected to this atlas, to the public atlas. The recommendations themselves are pre-computed, and I know I've been promising that for a year already. The code, I have it, I just need to put it on the GitHub. So you can recompute it for yourself, but they are pre-computed because they involve a lot of things, such as computing co-occurrence on the patient data, which one needs access to. And the flat file is living on the GitHub, on forums. So anybody can actually download it and look at it. Okay, and in the interest of time, if you have more questions, you'll have opportunity to ask them further. Now, I'm gonna skip all this. How you assemble them into the building blocks. The science of creating cohorts, if you go deeper into it, is a much bigger science that we would like to cover. What we really want to say here is that cohort is more than just a concept set. It's always logic of how patient enters the cohort, for how long the patient satisfies the criteria, and when the person exits. And now that you have these concept sets or building blocks, you can think of the logic of how to assemble these things into a cohort description or a cohort definition. And you can borrow phenotypes from literature. For example, there's this definition where they studied management of hyperlipidemia among patients with rheumatoid arthritis. So what they said is that we want patients with rheumatoid arthritis who were diagnosed first in their history. We want to make sure that they're adults. We want to make sure that they have coverage with the primary care physician. We want to make sure that they have 2 outpatient visits because we only want those who are followed up. And we want to make sure that they have a year of follow-up and no lipid lowering therapy on day 0. And what it would map to in our world is the entry event, which is the first ever diagnosis, and inclusion criteria, some of which we can understand from the paper, like more than 18 years old. Some of them actually require more specification than what's described in the paper. For example, they say, oh, we want the receipt of medical care from primary care physician. Receipt when? Receipt before the diagnosis, after diagnosis, on the date of diagnosis? From the paper, we don't know. And we do want to specify it in our definitions. So another thing that we promote all the time, and Dima will talk more about the storing phenotypes, is storing and reusing executable phenotypes, which means that when you take the file with a phenotype, you know exactly what you're getting, you can reuse it, and you don't have to guess what's there. Is it visit before? Is it visit after? You can infer from the executable JSON file what exactly happened in that cohort and how it was constructed. You can also think of other examples of how you would assemble those building blocks. You can think of somebody where you would want to use a building block of rheumatoid arthritis diagnosis and the building block of the measurements if you want to require those patients to also have elevated rheumatoid factor, for example, within the 30 days of their diagnosis. So now you're pulling in your building block of the measurements, trying to increase your confidence in this patient having diagnosis. Or you can think of a different definition where you say, I want hospitalizations with rheumatoid arthritis. So you would still use the concept set of rheumatoid arthritis diagnosis. In this case, you would use all events because you want all hospitalizations, and you would limit this cohort until the patient is discharged. So those two examples kind of high level showcase that there can be different assembly of the building blocks you have, and also different configurations in terms of what gets your patient into the cohort and what gets your patient out, depending on what you want to study. And all of that would be really informed by your research question and by your clinical description. That was really 2 cents on building cohorts. And with that, I promised you I'm gonna only talk for 20 minutes, so you know I have this clock. We're briefly gonna talk about evaluating phenotypes. And once you created your cohorts, and really, I encourage people to create multiple cohorts because you can have a clinical idea in your head, but you do not quite know how that manifests in the data until you execute this phenotype and you look at the patients that you got. So imagine you have a couple of phenotypes that you created that perfectly match your clinical idea. Now let's actually see if these are good phenotypes, and this is where the evaluation part comes in. And really the goal of evaluating phenotypes is to make sure that your definition really aligns with what the slide says, true health state, or in our case, what we think those patients should be and what we want to get. If we want to get patients with rheumatoid arthritis, evaluating this phenotype will get us an idea of how well this definition matches what we think rheumatoid arthritis is and patients with rheumatoid arthritis are. And the second bullet point that was kind of alluded already to in the audience is that when we evaluate phenotype, we're only seeing if it's fit for use in a given data set. And there was this question, if you can just reuse it without evaluation, and there was an answer that no, we really cannot. But it's quite important to stress it again, is that past performance on a different data source does not guarantee you the same performance on your data source. If you're getting phenotype from the literature, you're reusing it, unless you're reusing exactly same phenotype on exactly same data, you really don't know how it performs on your data. So it's important to do the evaluation on your own data source to actually see what you're getting and see whether this measurement error of a given phenotype impacts potentially your study results or not. And we have talked about, again, this is very high level, we have talked about some of the things that you want to look at when you're evaluating phenotype, and it's really 3 things. Is the specificity, or are you including only the patients that have the disease, or, well, it actually says on the screen, or you're also including the patients who do not have the disease. We want to look at the sensitivity. Are we including all of the patients that have the disease, or we are missing some? And we want to look at index event misclassification, because you can include just the right patients, but at the wrong point of time. And that is not really covered in the literature a lot. We do talk a lot about it in OHDSI, but index event misspecification is quite important because you do want to capture the person when you want it. Usually it's when they first have the diagnosis. It depends on your research question, but index event misclassification is something to watch out for as well. And there are several tools in the OHDSI community that let you do that. Assess the performance and look at index event misclassification. It's cohort diagnostics and phenotype R, and Anna talked about it in brief. This tool looks at the population level. You get your cohort, it tells you how the cohort looks. You can look at the counts, you can look at the baseline characteristics, You can look at the incidence of this cohort in the general population. You can see age, gender, year trends. You can compare this cohort to a different cohort. And all of that allows you to see if you're including patients that you want, if you're not including the patient, if you're including the patients that you like, and if you're including them in the right time. The cohort diagnostics, again, there are a couple of demos that we've done extensively across years, and by us, I really mean the community, not only us, that we've done on cohort diagnostics. The reference file will have, again, the links to the videos, but the idea here is that we'll look at the cohort and we see whether those characteristics align with the characteristics of patients we expect. And what do we expect? Well, we'll look at the clinical description, and clinical description informs what we expect to see. There is also individual level of review, starting with the chart review, and most of the times, people think of the evaluation as chart review, and they don't do it because it's expensive, it's time-consuming, and we see in the literature oftentimes that either people do really big evaluation with 2 reviewers, with a 3rd adjudicator, charts, 100 patients, they spent a year on it, they spent lots of money, or they do nothing. And what we are postulating is that there is a sweet spot in between nothing and everything that gets you where you want and helps you understand whether your phenotype is good enough or not. So that was just a side note about doing chart reviews, that not only chart review, you can do other things, which is looking at cohort diagnostics, or running the probabilistic tools such as Evaluator that will give you sensitivity, specificity, PPV, and PV. Or you can do profile review, but on the structured data. And this is the exercise that we're gonna do now. So finally, I'm gonna stop talking, and you're gonna do something fun. But for you to do that, we need to look at this clinical description again. I said clinical description with like 20 times, clinical description. For rheumatoid arthritis, the symptoms you're looking for in those patients are joint stiffness. Again, this is important for your next exercise. Joint stiffness, swelling, pain, nodules. If those patients are diagnosed in practice, there is a set of typical tests that one would do to figure out if those patients have the disease. They would do X-ray of joints, they would do MRI of joints, they would do lab tests. In lab tests, they would look at rheumatoid factor that you expect to be increased. They would look at the antibodies that you expect them to be present. And they look at C-reactive protein that, again, you expect to be high in those patients. Clinicians also want to rule out other diagnoses that kind of manifest the same way as rheumatoid arthritis. They want to exclude gout, psoriatic arthritis, other arthropathies, lupus, other autoimmune disease. And usually you will see the workup where a physician tries to figure out whether it's any of these things or rheumatoid arthritis. And this is what we call a differential or alternative diagnosis. And then once they decide that a patient has a disease, rheumatoid arthritis, they would prescribe the treatment, which varies from NSAIDs, such as ibuprofen, to steroids to help alleviate the inflammation in joints, such as prednisolone or dexamethasone, to more specific biologic drugs, TNF inhibitors, JAK inhibitors, infliximab being one of the examples of the drugs that are used for rheumatoid arthritis. And there can be multiple complications, involvements of other organs, problems with using your hands, and so on and so forth. Now, that is a brief clinical description that should help you do the exercise. And to do this exercise, we spin an OHDSI app, and we will get the link up on the screen. But you would want to go to that OHDSI in a second. This is the patient profile that is structured, that is constructed off of the structured data, and you only see things that are relevant to rheumatoid arthritis. This is not the full profile, it's just the set of the things that are only relevant. And we executed we get the data for this patient from one of the databases that we have, Optum DoD, and it has different buckets that kind of correspond to the buckets we just talked about when we think about concept sets and clinical description. So here we see that this is a patient who's male, 74 years old. They have observation period that is quite long, that amounts for almost 2 years, 10 years, right? Almost 10 years. They're white, they're Hispanic, and on the index date, they present to the clinic with rheumatoid arthritis of multiple joints as primary and secondary diagnosis, seronegative rheumatoid arthritis, again, primary, secondary diagnosis, multiple joint pain, which we know from the clinical description is a symptom of rheumatoid arthritis, and radiculopathy. Now the coloring. Green indicates that this supports rheumatoid arthritis, so that increases our confidence in patient having rheumatoid arthritis. Black is either. Red color indicates that it decreases our confidence in patient having rheumatoid arthritis. And I will get to that in a second. So they presented with this set of codes, and we know that this visit was an outpatient rheumatology visit, followed by the family medicine follow-up on the next day. Before that, they had no other symptoms that are relevant to rheumatoid arthritis or alternative diagnosis. They did have kidney stones and type 2 diabetes mellitus recorded a month before. They've never taken any drugs that are relevant to rheumatoid arthritis. They've never done prior treatments for rheumatoid arthritis. Then on the day 0, they had their C-reactive protein measured. They had erythrocyte sedimentation rate measured, and they had complete blood count. Here we don't have the results. For some of the other profiles, we will actually know what the results of those lab tests are. And we know from the clinical description that C-reactive protein is used when a clinician determines whether this patient has rheumatoid arthritis. There were no alternative diagnoses recorded, and if you click on this I button, it will actually tell you what kind of alternative diagnosis we are considering here. So in this case, it's spondylitis, it's gout, lupus, osteoarthritis, and so on and so forth. Those lists would be different for different diseases, but here the information button tells you exactly what we're looking at here. And out of this list of alternative diagnoses, this patient did not have any of them in their records. There were no specific diagnostic procedures. And then after the index date, we do see that this patient had diagnosis of rheumatoid arthritis multiple times, starting from the next day, then a month and a half, then 3 months later, all the way to 8 years later. So they've been consistently getting diagnosis of rheumatoid arthritis throughout their patient history after the index date. They got multiple diagnoses of rheumatoid arthritis of multiple joints, seronegative, seropositive, interestingly. And there is a bunch of other things that happened to this patient after the index date. We already know they have diabetes, they have chronic kidney disease, they have anemia, there was hammer toe, there was hyperkalemia, kidney stone, spinal stenosis. So a lot of bad things happened to this patient. Nonetheless, if we look at these things in red, we don't see any other alternative diagnosis, any other autoimmune disease that would make us think this patient doesn't have rheumatoid arthritis. And this patient has taken infliximab, which we know from the clinical description is used to treat rheumatoid arthritis, as well as methylprednisolone, which is a steroid, again used to treat rheumatoid arthritis, for multiple days throughout the years after the index date. He has arthrocentesis done, as well as some manual therapy, as well as some of the exercises to help them develop strength and endurance, probably because they had limited mobility for whatever reasons. And this patient is not dead. So based on this totality of this information, the fact that patients have multiple diagnosis codes of rheumatoid arthritis, they have lab tests done, They have treatment that supports, that is used for rheumatoid arthritis. All of that supports the fact that probably this patient does have rheumatoid arthritis. So if I were to review this profile, there are tabs for me to indicate whether I think it's case, non-case, as well as my certainty. And in this case, I think it's a case based on the totality information, and I do think that it's a high certainty that this patient has rheumatoid arthritis. So this is the way I would go through this profile, and there are 3 of them for you to review. So in the next 20 minutes, or depending on how fast all of us are, or 15, you, together with your neighbor in pairs, are going to review the other 3 profiles, and you're going to write down on a piece of paper or on your laptop whether you think each of them is a case or not a case, or in other words, whether you think this patient has rheumatoid arthritis or doesn't have rheumatoid arthritis. And you're going to write it down, and then 15 minutes later, we're going to reconvene to see what you get. Now, to do that, again, you would go to this website. And once you go to this website, we will also pull up clinical description for your reference. And you want to do this in pairs. And I don't see people talking to each other. So do you have your neighbor to work with? It's results.odyssey.org/app. And once you go to apps, you can just browse in the catalog, so you don't have to copy all of it. Bigger, I can make it bigger. I can make it very big. What's up?
How long?
Huh?
How much time do they have?
15 minutes.
15 minutes.
1-5. Okay, so I'm gonna, so you go to this website, and I'm gonna switch to clinical description in, let's say 10 seconds, so that you have it in front of you. Huh? Huh? Is everybody on the website? Is it working? No? Okay, let me walk and see what you guys getting. Well, actually, let me see what I'm getting. Oh, it's not loading. Okay, can you show hands who got to the website and it works? Okay. Okay. Can you keep the hands raised? Who got to the website and it works? Still loading. Okay, can we assemble in bigger groups then? So let's work row by row. So these 4 people, then you have 4 people too, and then we're gonna do this row, split it into 2, and then I think we have 2 groups per row, so that if we don't hit unresponsive, yeah. Yes. Okay, let's give it a second. Let's not click on anything, and let's try to see if we can actually resolve it.
Yeah, I actually can't get there as well.
Huh?
I can't get there also. So
Yeah, that's why I said let's not click on anything for now. If we click too much and we broke it, then I will go through the profiles one by one, and you will think of whether you think each of them. Okay, so let's do a backup plan, which is I will go through profiles, and you would write down whether you think those patients is a case or not. So that is less fun than clicking yourself, but the RShiny is up, so you can return to it any time if you want to have fun with it. Okay, so let me just do it myself. Okay, sure. Well, before that, I was supposed to get 3 answers from you, which are not in sequence, but now because I'm going to be reading the profile, actually we can have a poll everywhere so that you will be answering for each patient. And I think. No, I can't because I'm stopping the app. Yeah, should have. Never mind. Okay. You know what? Let's do the following, my dear friends. Not to waste your time, Dima is going to talk about now you evaluated phenotypes, how you maintain them, and how you track changes. And then afterwards, we're gonna go back to this exercise because we don't have to do it now. And also, I don't want to waste your time by just sitting there and doing nothing.
Ты тоже не можешь сюда зайти, да, на этот кипр? Ты тоже сюда не можешь зайти, чтобы показать всем, правильно?
Да.
Okay.
So, we're gonna switch to the phenotype maintenance and tracking changes, and then we're gonna go back to the exercise.
All right, so still have like 30 minutes-ish.
You have 20.
Yeah. Guys, so I see some of you still explaining and talking about, probably some of you got this shiny and you got the core and you have something to discuss, right? No, nobody could get it. Okay, so then you don't have a reason to talk now, okay? Not a good reason to talk. All right, so I'm going to talk about how you maintain phenotypes. My name is Dima Dimshits. Maybe some of you know me, maybe most of you know, but if you don't know me, I'm Dima. I'm Dima, Dimitri or Dima. And thanks to Anna, she put this very nice pipeline. So basically we go from what is a phenotype, right? Then how you develop it, how you assess it. And finally, if you do this nice piece of art, you store it somewhere in a museum or whatever. So or a library, if it's like a piece of art is a book, right? So now we will talk about how you store and how you curate it. So I'm going to talk about a few libraries we have. OHDSI phenotype library, J&J phenotype library. I want to talk about a little bit about my organization, how we do that. So maybe you will encourage it by that and use similar processes, similar principles to store your phenotypes. Also, we have Darwin core knowledge base, but I'm not going to talk about that like in detail because it's so not that much of a time, right? And Cypher, which is maintained by Veteran Affairs. It's a US Veterans Affairs, which has not only OHDSI, but all phenotypes in different formats. So it's interesting because, well, basically you can now just Google it or use Anna's links and see what are those phenotypes, right? Not only OHDSI, but you can use them and transform into OHDSI format, or you also can submit to make our phenotypes shared not only with OHDSI people, but with everybody else. Okay, so what's the OHDSI phenotype library? And there was already a question, right? Okay, but who's asked? Probably he went to. So the OHDSI phenotype library is basically a
place where you store phenotypes, right? And the distinct point is phenotypes are not endorsed by the community. So which means if I submit my phenotype to the OHDSI phenotype library, there is no specific unit, like librarian wouldn't check if clinical content is correct. They only check if the structure is correct, if rules, if formal rules of OHDSI database, this are followed. So basically this is like a community contribution where someone can submit cohorts and someone else can run them and see if it's good or not, right? Of course, like it's responsibility of a submitter to submit a good cohort, of course, but then as a community, I don't think it's a good way of saying that, like shared responsibility. Yeah, because if someone in the class make a bad thing and they say, let's all stand up until those who made a bad thing say that, right? So shared responsibility is probably not a good thing in general life, but well, something like that, right? So someone can check and see if it's good or not. And again, talking about shared things, shared knowledge, the libraries exists for reuse of phenotype library. Well, in your organizations, like something you created 3 years ago, right? And then 3 years ago you had a study on rheumatoid arthritis drugs, and now you want to study rheumatoid arthritis complications, whatever. So you use the same phenotype you created 3 years ago. And you can share it across community, right? That's why we have OHDSI phenotype library. So if I created that, you having a study on rheumatoid arthritis, I don't know, characterization, you don't need to create it de novo. So yeah, that's a good thing we have. And here you can access it. So this exists as a R package, so you can install it and query it. Later, I'll give you the link to the, basically you can clone my repo for that workshop, and there will be like a snippet of a code, how to query it. And this is also exists in the GitHub, as usual. As usual for OHDSI, it's open source, so you go to GitHub and get it. And it's about 1,000 of phenotypes. And the proper question is like, okay, how they end up there? Like, they not magically appear in that thing? So you need to submit a cohort. And basically it's about the question, how do I know details about the cohort? So when you submit it, you create a forum post, OHDSI forums. I don't know, probably all of you familiar with that. Nice, almost like a social network. Once I had we had a duty, you needed to answer the OHDSI, like you spread knowledge. We had a duty, someone is on duty to answer the forums, and it was fun. It felt like I'm engaging in the social network. So anyway, OHDSI forums, you can find the cohort. For example, if you click on vasculitis, then you'll, I don't know if this link is provided, but you can basically search vasculitis phenotype library submission, and you see this nice post in this forums. So here's an example. Also, here in the GitHub there is a CSV file that keeps all our cohorts. So you can just do Control F on that, search that file, and find your cohorts and get basic information, basic metadata on it, while more detailed information is obtained through our querying, through our package. Then also we have a nice resource, which is also probably will not be accessible easily if all of you will try to click it right now, but if you do it one by one, it will be. So this is like a OHDSI phenotype library cohort diagnostics. So you can not only you have cohorts, like definitions, but you also have information about that cohorts. Run on 11 data sets. Well, you can see that there's a slightly bigger count of cohorts because we also added some April run of something that wasn't yet in April phenotypes, which is, how is it called? Phenotype, yeah, just like that. So, which is not a part of the phenotype library yet. So, you see cohort counts. You see cohort definition. So, yeah, the main point, sometimes it's frustrating. To me, it was actually frustrating that those phenotype library is not an atlas. It's not an atlas demo. It might be someone copied that by intent. It's not there. So you need to find the definitions elsewhere. So here on that page you see human readable definition. You also can use JSON and export it. So basically you can see the way you did it, you get JSON, export from here or from our package, and then import on your atlas, and you get it. Also, you can have incidence rate. Basically, we see age, sex, and calendar year distribution of events. So it's actually a good thing to validate your cohort. For example, you expect that it is more prevalent in females and it's more prevalent in older age. Just typical picture for array. So you think, okay, I made a good definition. Again, they are what, 2 hours, 3 hours. So some longer, really detailed workshops on how you do the cohort diagnostics and why is it so important. Okay, so a few words about J&J phenotype library. So this is internal phenotype, an internal thing, and we also have definition in our atlas and supporting documentation separately, right? So this is an example of our metadata. And what's important is created date, modified date, and vocabulary version. We will talk about that later, why it's important, because basically vocabulary changes and how your cohort definition behaves can be different because of vocabulary, right? And also we have an author, so I know who I ask if I have questions about this cohort, and clinical description and evaluation summary. So here you have this supporting document, which is quite important thing, quite important artifact alongside of a cohort, because here you can understand why people choose that decision or why they choose, let's say, let's have 2 array codes within 30 days to make it more specific, or let's add drugs like as one of the criteria, right? And there is a full explanation. So here to the left you can see the basically clinical description, executive summary, recommendations of why it was, then core diagnostics report, what are the characteristics and what is the performance of the score. So basically it gives you the full information why that exact definition is in there. Okay, now you can ask me why this mirror thing is here on the slide, right? Anyone has an idea why is it here? No, why is it on the slide? Yeah, it's here. It's just here. So why is it on the slide? Right, exactly. So actually I was pretty surprised that this is a depot. It's like how you store. So from the recording answer was, is this a depot for storing phenotypes? Oh, sorry, storing course, storing pieces of arts, right? So storing the pictures, paintings, yeah. Sorry. So yeah, this is like that thing where you store, and they also do maintenance of these pieces of art, and we also need to do the maintenance. First of all, due to the vocabulary change, as hierarchy can change, and you know, as it was already explained, you get the high concept in the hierarchy and look at the descendants, and sometimes they can say, oh, well, those descendants are not descendants anymore. And also need to align with clinical trends. Sometimes the definition change or something, right? So you need to maintain it. And here I want to present the tool that is called Alatea. Alatea is a Greek goddess or basically spirit of truth. So in here we want to know the truth about your phenotypes and how truthful is it in spite of vocabulary changes. Also, so here's one GitHub for the package itself, and another GitHub in down below. It's for that workshop, so you can clone it, and they will be again code snippets for what I'm talking during this 30-minute session. So what's detected by Alatea? Non-standard concepts use concept set definition. So 2 years ago they were standard, now it changed to non-standard, and basically they don't do anything for your definition unless you want to query non-standard concepts, but usually you query standard, right? So basically changing hierarchies and mappings, concepts changing domains. Basically, if you say your pick the condition concepts, you also need to pick the condition table in cohort definition, right? If these concepts change to observation now, to get them, to get patients with those codes, you need to query the observation table. So you need to change the phenotype definition. And approximate number of persons affected by the change. So let's review it. So basically it looks at concept sets, not in a cohort structure. Yeah, because basically concept sets is what's changed due to vocabulary, right? And this is a concept set of rheumatoid arthritis based on January 2023 vocabulary. And here we run the tool. Like there's an R package, you just Control A, Control Enter, and then you get the results. So basically, you see the vocabulary versions you used, and then you see the stats tab. So in a rectangle, this is like a ratio of same persons, no change, to total number of persons. So here you see so the bigger the number, the closest is to 1, then the less changes you have. So on the first glance, it's a big number, very close to 1, so I shouldn't worry. But sometimes it can be. So this is very, very approximation. So imagine you have one big concept set, and then you have like a criteria that is a bottleneck. So imagine you have something in that bottleneck criteria, some change, and then total number of patients will be small, difference will be small, but the overall cohort change will be big. So even if there's small changes on that approximation, it would be nice to review and see what happens. So non-standard nodes, nothing here. None of those concepts from this list not become standard. All these are standard during that time. No domain changes. Well, they keep the same domain, so no worries on that part. But basically, if that, maybe I'll have time. So Anna, when do I need to finish? Bis 15? Okay, 15 minutes before. Okay, so yeah, and this tab, well, unfortunately, or probably for maintainer, unfortunately, because it adds more work. Unfortunately, this tab is not empty, right? And here you see that in the first row, unspecified juvenile rheumatoid arthritis is removed, and maybe someone can answer the question: is it good for RA arthritis? We already know what clinical definition is. Do you think it's a good change or not? Like the first concept, unspecified juvenile rheumatoid arthritis, is removed now. Is it a good change? Like, did vocabulary change, did good for that cohort or bad? Is good. Okay. Okay, I agree with Vlad. Because yeah, basically it's very confusing thing because it named in ICD-10, it named juvenile rheumatoid arthritis, but when you go to read the literature and do the research pathophysiology, it's actually different pathophysiology than rheumatoid arthritis. So this is basically a shift in diagnostic paradigm, a shift in naming and in diagnostic. Now we know that this is not an array. And basically in SNOMED, you see the mapping is changed. So now it's mapped to juvenile idiopathic arthritis. So this is and SNOMED basically gives a proper name. It's juvenile idiopathic arthritis. But before, we mapped it to juvenile rheumatoid arthritis. It was a thing. Maybe it's non-standard code now. So it was mapped to array. So that's one case. And another case, it's faulty syndrome, rheumatoid lung and rheumatoid nodules are removed. So I won't ask if it's good change or bad because you'd never know because it depends on the clinical intent. It's a pretty important question. When you create phenotypes, what do you really want to capture? So here it's extra articular rheumatoid arthritis. If you want to develop drugs that's systemic, you want to keep that. If you want to develop the ointment for the arthritis, you probably don't need those things, right? So that's arbitrary, but imagine we want this extra articular things, and then to do that, to keep those concepts. So the thing is that SNOMED actually moved those concepts like faulty and lung disease, to another hierarchical branch. So to fix that, you need to add another concept. So now, to the definition you had previously, we have to add extra-articular rheumatoid process, and now we get the same list of source concepts. Alatea also supports comparison on two cohorts. Like basically when you fixed, then you can put together old vocabulary, old cohort, and new vocabulary, new cohort with new ID, and then compare to check how well your fix went. Well, I think, so do we have time, right? A little bit. So we can go quickly through the other tabs. So as basically in array, we had these tabs empty, but for other cohorts, for example, for neutropenia, you just see that, hematocrit measure, it's the concept name, but the node concept, the node is like the thing you see here. So this called, each concept that exists in definition itself, it's called node. So this node is non-standard anymore, and even if it has replacement, the tool gives you replacement. So basically, it's very easy to update your cohort. Just use the replacements instead of codes that are non-standard. And the trick is here. So well, you should be aware of that. So once you create a core definition in Atlas, it creates a JSON object. And when the vocabulary updates, it doesn't update the JSON object. So if concepts become non-standard, you don't see it on the screen. So basically the question is like, why do I need a tool to see if concepts are non-standard? You see those red concepts if they're non-standard. But the point is that once you create concept set, it doesn't change. So you will not see those concepts as reds if they change over time. So that's why, well, probably we can do the change in Atlas, but why not create a simple tool that will show it? As part of, anyway, you need to maintain cohorts. And then domain change, well, again, so you get the cohort ID, concept set name, so you know where to look at, and then concept ID that had changed from condition to measurement in this case. So if you see that, you need to add another table or look at that. Maybe this table already is there, but you need to review the domains. All right. Questions?
Actually, there is one more thing to add here, which I was hoping to add on the last slide, is that we use this tool all the time when the new vocabulary version gets out. And we update all of the phenotypes so that they align with the new vocabulary version. Because at each point of time, we only use the most recent vocabularies for our data. But a lot of the institutions here are on the different vocabulary versions. And they have a very legitimate challenge of, well, how do we know how those phenotypes resolved on all of our data sources, given that we are on different vocabulary versions? You really should be on the most recent vocabulary version. You really should. But if it happens that you're not, there needs to be mechanism for you to know about what it means for your study to be on a different vocabulary version. And Dima has been shown Alathea, which you can use to see the difference in between two given versions. Marcel here is also working on the tool that also showcases the difference in the concept set definition across different vocabulary versions. And he has a very nice visual for showing the differences across 1, 2, 3, 4, 5 different vocabulary versions. I really wanted to add a link to the tool in our reference. Unfortunately, it is not on the GitHub. So if you're interested in learning about what Marcel have been doing in that space and seeing his nice visuals, he's sitting right there. Please come to us or to Marcel because the visuals are really nice.
Yeah, no worries. Thanks for adding that. And yeah, and also when it's actually interesting because in my career, before joining J&J, I was working on the vocabularies, and I wasn't at all. I wasn't working with phenotypes at all. And when I joined J&J, my basically duties shifted more to phenotypes, and I was surprised. And I was sure that still exists because I never touched phenotypes. What is still? And I knew how vocabularies change. I was sure it will exist, but it didn't. So I developed it by myself. But yeah, I was surprised it's not here. Because probably if you are a vocabulary guy, you know how vocabulary is changing. If you're not, you don't see it. You see the, the release notes where it says, oh, we did all these good things for you, but you never think that it can be basically disruptive for your cohort definitions, for your process. Okay, anyway, just wanted to share my impression. Questions? Uh-huh. I'm sorry.
How does the peer review for the OHDSI phenotype library works? That was the question.
Yeah, that's a good question.
Gotham, who is a librarian of the OHDSI library, he looks at your submission, and if it is executable and it has clinical description, he takes it in. That is really the peer review. Because as Dima said, there is no such a thing as OHDSI endorsed phenotype.
Yeah, but actually that's something we really lack in now. Like there is no process that says, like as you can see, cohort ID 2, so it's very beginning. So it's here from 2021. It's still saying pending peer review. So we don't have this process really established yet, basically. We need to work on that.
It only means that Gotham didn't get to it. So yes, if you would like to contribute to phenotyping, phenotype libraries, or the fact that a phenotype from 5 years ago is still pending, every Friday there is a phenotype work group, and Gotham is there, and you can come and say, hey, I think you are lagging in your responsibilities.
Yeah, so I believe that it should be done this way. So if you reuse this cohort, if you decide to reuse this cohort, you don't reuse it blindly. You take all this consideration, like evaluate it, and then if you evaluate it, you can say, yes, I peer reviewed that while I was using that. So probably it was in mind, but as we can see, it's not going as like on this level, or on that magnitude as it was planned initially. I saw a question from there. No? Hmm?
The question was, should we map, should we put measurements in the measurement table? And when you create concept set, can you always expect that measurement table has measurements? Do you want to answer that?
Yeah, sure. So, well, you can create one concept set with all concepts. Like for example, here you can see that it's condition observation in the same concept set, and then when you put the building blocks of the phenotype definition in Atlas, you can say it's in condition table and put this thing while it has observations. So it will just ignore observation concepts that are, if they are added to the condition block, or and vice versa, then observation block, and it will ignore condition concepts in that concept set. But if you, like in this case, if I only put this definition only in condition table, then these concepts that are marked observations wouldn't be captured. So patient who only had a CPT code for arthritis and nothing else, and I didn't specify observation table, then those will be missed. Is it the answer for your question, or you mentioned something slightly different? Right. Well, if it's, so when you create cohort, you usually you can address one table, right? You can address all tables. You can say it's condition or observation or measurement or drugs, like all tables. And then, yeah, you don't worry. But usually people just say, okay, if I look for a medical condition, I will create a criteria, search patients in condition table. And if I don't add observation table, then I miss those.
But all the measurements should be in the measurement table.
One more question? Okay.
If you do want to do exercise,
Yeah, sure.
but if I, even though, well, let's see if I can get it back. Why is it? Well, if I cannot get it back, then we will have more questions, of course. Yeah, why don't we ask another question? Was there another question?
I mean, if you have any questions, it's a good time to ask.
So the question was how those 4 patients were selected. And the way those 4 patients were selected is that I executed a cohort of patients with rheumatoid arthritis from the phenotype library. And I selected 4 patients that are nice patients that illustrate the idea. If you were to do that in real life, you would either sample a random sample, such as a random sample of 200 or 1,000 patients, and you would review them in the same way that this chart review is done. In chart review, you usually take 200 random, or 20 or 100, depending on your power calculation, patients, and you review their charts. So here is the same idea. You sample patients randomly, you review them, and you derive your phenotype performance from how many cases are in that sample. You can also use LLMs to adjudicate the profiles and make the determination for you. And I think it's actually not happening, guys, you know? It's still loading. So I think I promised you fun, and I actually am failing you miserably because we totally brought results.odyssey.org down. And okay, well, that was supposed to be fun, but instead you can have your time back, which is also good. Essentially, I hope that so the way it was supposed to go, Dima is suggesting all of the cool stuff we can do, but it was all relying on your reviewing profiles, because then you wouldn't really see the point. But I feel that this RShiny will be back in an hour, or when we finish this workshop, it will be back up. And this RShiny has three other profiles of patients that you can look at, and we will give you the summaries that were generated by LLMs to show you what LLMs actually tell about those patients. And you would see, if you were to do this exercise, you would see that your thoughts about the patients aligns very closely to what LLM says. And we have a couple of experiments showing that when LLMs adjudicate those profiles, they adjudicate them just as bad as as the real people do that. Now, that being said, again, we failed you badly because the fun that was promised is not there. Try again. And maybe Patrick's gonna save us. Who knows? Is it? No, don't say hop before we actually jump. Oh, you see? The moment I was ready to give up. But I think somebody helped us from down there. Okay, wonderful. So let me walk through these profiles. And again, I kind of gave it away by saying that these were selected to illustrate for the illustration purposes. So these are on the nice side. This is a female patient, 41 years old. They have lots of observation period. They have like 10 years of observation period. They're white, they're Hispanic, and they came in with the lab visit and with the pharmacy visit. And on the day of this laboratory and outpatient visit, the diagnosis that were recorded is osteoarthritis, primary, secondary diagnosis. And we remember, okay, I'm not giving it away yet, rheumatoid arthritis, primary, secondary diagnosis, and vitamin D deficiency. We can see that there were no relevant symptoms, and there was hallux valgus, which is deformity of your toe, 2 years before. This patient has taken steroids, betamethasone, dexamethasone, NSAIDs, ibuprofen before. They've taken meloxicam, which is also an NSAID, and have taken other steroids that can be used for rheumatoid arthritis, but also for other conditions, multiple years ago and a year and a half ago for a short period of time. Then after the index date, after this first visit, that's before. The prior treatments included things like manual therapy and some therapeutic exercises that they got 2 years before the index date. Now, on the day 0, we see that they had C-reactive protein, and it was normal. We also see that they had complete blood count, all sorts of blood work. This is generic blood test when you get to outpatient clinic or inpatient clinic. So the most important thing is that they got C-reactive protein and it was normal. They also had a diagnosis of osteoarthritis on the day 0 and a month later. And they got multiple records of rheumatoid arthritis after the index date. So they got diagnosed with rheumatoid arthritis again a month ago, 3 months ago, a year ago, year and a half, 2 years ago, and they got diagnosis of seropositive rheumatoid arthritis again. After that, they were treated multiple times with NSAIDs, with steroids, they actually started steroids for 2 months right after this first day. And they also got some sort of long-term drug therapy a month after and half a year after. So we see here that they got their diagnosis, they got some prior relevant treatments, they got some lab tests that are indicated for rheumatoid arthritis. They did get a diagnosis of osteoarthritis, which can be a diagnosis of exclusion, and they got multiple diagnoses of rheumatoid arthritis along with treatments after day 0. So now I guess the question is, do you guys think that this is a case or not? And to do that, we are going to go to Poll Everywhere. So you are going to go to pollev.com/Patrick Ryan. Of course, that is the poll everywhere that we use all the time. Patrick Ryan 800. Is it 800? Polleverywhere.com, Patrick Ryan 800. And stay there because we're going to use it for all of them. And you're going to choose, do you think this patient has rheumatoid arthritis and you're sure? They have rheumatoid arthritis, you're not so sure. They don't have rheumatoid arthritis, but you're still unsure. Or they do not have rheumatoid arthritis and you're really sure that they do not have it. And we're gonna give you another 5 seconds. Is everybody? 15 people voted so far. And, 17. I can see the number. Okay, there are more than 22 people in this room. Okay, let's get this to at least 30. We got it to 30. Okay. So now, as it is slowing down, 38, 39, 40, okay, now I feel that we do have a representative. So people think, most of the people, almost half of the people think that it's a case, but they're not sure. And another more than third thinks that, and now people changing their walls because yes, you gotta follow the crowd. And a third of people really thought that it is a case and they are sure of it. So now we can also look at what LLM thinks about this case. And LLM tells us, and these are the paragraphs that are generated by LLM when they look at the same patient profile that you just looked at. So what it says is that, well, this patient has multiple diagnoses of rheumatoid arthritis spanning different days, and the persistence and frequency of these codes across many encounters argues against a one-time rule-out diagnosis. This patient started on multiple treatments for rheumatoid arthritis, sulfasalazine and methotrexate, as well as a long-term prednisone treatment, and these are likely to indicate that they have RA. It also says that even though the lab test on the day 0 shows normal C-reactive protein, rheumatoid arthritis can have normal lab markers. And the fact that this patient had seropositive rheumatoid arthritis on day 420 further corroborates the diagnosis. So the LLM thinks that this patient has rheumatoid arthritis, which aligns with what you guys think, most of you. This is patient 1. This is the patient 1 that you just saw. Now let me go to a different one. Meaning patient 1 is not patient 2. So that was related to your sequence. Now we can look at, and let's do 2 instead of 3. And this is actually a good example of another one. So this patient is 68-year-old female. They also have lots of observation period, which is kind of not typical, but they have like multiple years. That's, I think, 10 years of observation period. They're also Hispanic. And on day 0, they presented to an outpatient clinic, and that's an internal medicine visit. And they presented with rheumatoid arthritis, which was a secondary diagnosis, and foot pain. And there was another primary diagnosis that is not relevant to rheumatoid arthritis. So they had foot pain and they had rheumatoid arthritis. They had no prior symptoms of rheumatoid arthritis. They had a diagnosis of osteoporosis, which is low density of your bones 2 years before. And they had problems with their shoulders where there is accumulation of calcium. Is it calcium? I think it's calcium. Calcium in your shoulder 2 years before. This patient also has diabetes mellitus that was first probably diagnosed 2 years ago, approximately. This patient took, among the relevant drugs, this patient took acetaminophen, which is just a general NSAID 2 years ago, as well as oxycodone for some sort of pain 2 years ago. Now, after the day 0, we see that this patient got rheumatoid factor measurement. We don't know the result on day 13. They got specific antibody measurement for rheumatoid arthritis on day 13 as well. We don't know the result. They got measurement of C-reactive protein on day 13, as well as measurements for lupus antibodies on day 13 and complete blood count. Here we don't know the results. We just know that they got those tests. We also know that on the day 13, they had the diagnosis of primary osteoarthritis of hand, which we know is an alternative diagnosis for rheumatoid arthritis. So that would do, I will not say what it would do. This is one of the alternative diagnoses. They also got bone density study on the day 27. And after the day 0, they had one diagnosis of seropositive rheumatoid arthritis on day 13, multiple diagnoses of osteoporosis, and multiple diagnoses of type 2 diabetes without complications. In terms of drugs, they were getting a bunch of drugs, NSAIDs. They got steroids, that's like, 5 years later for 15 days. And another steroids 2 years later for 6 days. They got some antibiotics, more antibiotics, painkillers, and some more antibiotics. There was arthrosynthesis, which is an injection, in this case, injection in joint, done 6 months later after the index date. So to recap, this patient came in with a foot pain, one diagnosis of rheumatoid arthritis. There was osteoporosis. There were a bunch of workups done on day 13. And that was the single next diagnosis code that they got relative to rheumatoid arthritis on day 13, and no more diagnosis codes. There was a workup, we don't know the results. So now, based on the totality of this information, would you think that this is a case or a control, and then what's your certainties? I feel very certain about this one. Although I'm not quite sure I wanted to balance in between expressing what I think about this patient and not expressing it so that you can think for yourself whether you think this patient is a case or not. Okay, and we want to get to like, we get 40. Now you are fast. Okay, so now let's see what this patient, yes. Let me just pull up. This is blah, blah, blah. Okay, so what do we have? Okay, before you guys moved your answers, half of you thought that it's not a case with the low confidence, and then there were people who thought that it's not a case with the high certainty. But it's kind of the same, what we saw before, is that most of you stick in the middle in terms of certainty. Now, what do we think the LLM says? This is what it says. So there are only 2 diagnosis codes for rheumatoid arthritis across this. I said 8 years, it says 10 years. It was day 0 and day 13. And these codes occur exactly at the time of the extensive laboratory workup for inflammatory arthritis. A classic pattern of evaluation to rule in or rule out rheumatoid arthritis. After that, we don't have any diagnosis codes across 8 years. And this patient never received any specific treatments. They received steroids, but they never received any biologics, any other drugs that are specific to rheumatoid arthritis. And there were 2 procedures on joints done that can indicate that this patient has osteoarthritis rather than rheumatoid arthritis. So together, and that's the last paragraph, the LLM thinks that it's not the case. And I actually agree with it, and you agree with it too, it's just you're not really certain. So in the first case, you were aligned mostly with the LLM, but not certain. In the second case, you were mostly aligned with the LLM, but not certain. And I think that's because you only learned about this disease 30 minutes ago, and we spent 2 minutes talking about it, and then you stared at the screen for 2 seconds while I read it to you. So if it was a real review, I would expect you to have much more confidence in the choices that you make. And I think even though we were in this very tight time-wise conditions, you still very much aligned with what LLM said and what I also think, because those cases were selected by me to illustrate this point. All of that being said, Keeper does allow you to review profiles in the same way you do chart review, and it does allow you to use LLMs to do review for you too. We are at time, and we are going to take questions, but also for everybody else who wants to enjoy their break, please feel free to do so. Please look at this QR code because the QR code brings you to more information, more workshops, and descriptions of the tools that exist in the OHDSI community that we have not covered. And there are many more things that developed for phenotyping by this community. It's in the file. We weren't able to cover all of it, but hopefully now you have an idea of how we think about the full pipeline from start to end. Many thanks for being here. I hope you enjoyed it. You really are free to go. If you have questions, come to us. And many thanks to Patrick for solving my technical issues.